Daniel, this paper that came out today describing humoral immune response to the SARS-CoV-2 virus in Iceland, how was the study designed?
The design was based on several questions that we wanted to get answers to. The first one was, when did the virus come to Iceland? Then we wanted to know the spread of the virus in Iceland, and we wanted to understand how basically the immune system responds to the virus in those infected, and how that response develops with time.
So, and by developing over time, you include there whether the possibility exists that the titer of the antibody declines soon after infection.
Yes, we wanted to see when it peaks and whether it would start to decline within the basically study period, which was up to 4 months.
And this was a study that included over 8% of the population of Iceland.
Yeah, well, we actually, I think we typed around 30,000 samples, which, yes, is around 8% of the population. Of those, we collected samples from 1,200 people that had been infected, and most of the remaining samples were either pre-pandemic or kind of a random sample of people either in quarantine or just the population at large.
And the results coming out of this were?
Yes, so there are several results. First, of interest to people in Iceland, at least, is that the pandemic had not arrived before February 2020. That is quite clear that it had not established a substantial foothold before then. We see that around 1% of the population of Iceland has been infected, which in kind of epidemiological terms is basically nothing. So we're still quite vulnerable to a second wave. Among the infected individuals, the pan-IG assays, which were most reliable, which basically measure all immunoglobulin, were rising quite rapidly within the first month or two after infection, but after that basically plateaued. We did not really, in those kind of the primary assays, see any evidence of decline. Some subtypes showed evidence of decline, but overall, in the global, the pan-immunoglobulin assays did not. They plateaued.
So there was a fairly rapid increase in the titer of antibodies soon after the infection for about 2 months. Then it remained stable, and there has not been a substantial decline in titer up to 4 months after infection. But then there was some correlation between the humoral immune response and the severity of the disease.
Yes, generally the more severe the symptoms, the stronger the response, and the response correlated with some aspects of, for example, the immune response was stronger in older people than younger people, and for some assays the response was stronger in men than women, which coincidentally, or maybe not coincidentally, is kind of mirrors how severely people get affected by COVID-19.
The big issue that is coming up these days now is the possibility of reinfection of those who have been infected. And one of the things that came out of this is that only 91% of those infected had antibodies against the virus. So what is that trying to tell us?
So it's a little bit more complicated. 91% had very strong antibodies that were robustly picked up with both pan-IG assays. let's say 4% had antibodies that were picked up by one assay but not the other, but then we were left with around 4% that consistently did not have any antibodies at all detectable by either pan-IG assay. So that either means that there's a false positive rate because this is based on a truth set, which is basically true positives, truly infected people, and they were identified with another test called the qPCR test, based on nasal or throat swabs. Either there's a false positive rate there of around 4%, or there are some people that get rid of the disease or the viral infection through other means than the antibody response. That could be T-cell mediated, for example, or some other means.
Do you know whether there was any correlation between being antibody negative and the severity of the disease?
Yes, generally there was an overall correlation of antibody levels and severity of disease, and in particular the people with no antibodies were slightly more likely to have not been severely affected.
So which would support the possibility that we are looking at just those who were victims of false positive qPCR.
It is a little bit tricky because we actually performed RNA sequencing of all the qPCR samples, and these people, there was no difference between the people with antibody response and without an antibody response in terms of having sequenceable virus, which kind of confirmed the qPCR result. However, it is always possible that some of these false positives were not kind of experimental false positives, but rather something like sample mix-ups or sample pollution that would create kind of repeatable results. So no test is perfect. So there has to be some false positive rate, but 4% sounds 4% of those diagnosed sounds a little bit on the high side, but yeah, it will be exciting to monitor that in the future with more experiments.
So what else would you like to tell us about this study?
So yeah, there were several results we found interesting. For example, Iceland has had a very aggressive testing strategy. So people with symptoms and exposure to the virus have been tested quite systematically. People have been placed aggressively in quarantine, but there was a low threshold of testing if you were in quarantine because of exposure. But still, of those, over 2% were antibody positive, which is much higher than in the general population, and which indicates that there is a substantial fraction of people that do not develop very severe symptoms that are sufficient to warrant qPCR testing. It also points slightly to another thing. We talked earlier about the false positive in the qPCRs, but there's definitely false negatives in the qPCRs in the sense that I'm sure the test is quite sensitive if there is an active virus in the sample you take, but a person could have been infected with the virus but not yet developed enough viral load to get a positive test, and then the virus doesn't uniformly infect the whole body at the same time. So you could have infection in another part of the body than that was being tested. So there's kind of, because of that, people could have been tested negative even though they were truly infected. The test is definitely not perfect that way.
But one of the things that I think is interesting when you look at these results is that if you take just random Icelanders who have either not been qPCR tested or have turned out to be negative, the prevalence of anti-SARS-CoV-2 antibodies is 0.3%. But when you look at the people in quarantine who have not been qPCR positive, their positivity rate for the prevalence of antibodies 2.3%, which shows that their tracking team really put in quarantine people who were truly at risk. Absolutely. So it shows that they did the work pretty well.
Another thing I found interesting is that there were a couple of kind of hotspots of infection in Iceland, and that is reflected in the qPCR positive. That was the active screening going on while the pandemic was raging in its first wave. But that is not reflected in the antibody levels, which indicates that the authorities managed to contain the pandemic quite well with these active measures of quarantining and other things. Another thing I found interesting in the quarantine data is that there's clear evidence that especially household exposure is extremely likely to lead to infection. If you take together qPCR positives and antibody positives, almost half of household members get infected. If a person introduces the virus into a household, almost half of household members become infected, despite isolation efforts and all those things.
So it basically indicates that the people within the same family have a tendency to interact more closely with each other. Absolutely. Than with the outside world. So it is basically a complicated way of belaboring the obvious.
Well, it has impact. For example, if as things are done in Iceland, if I get infected, my immediate family is put into quarantine, but probably you should put their contacts into quarantine immediately also, because they're my immediate family is so likely to have been infected that usually the contact tracing only takes one step. It only quarantines my contacts, but probably it should take 2 steps when it comes to my family members.
But if we sort of pick out the 2 most important observations, if you look, or the observation that has the greatest implication for other populations. Number 1 is that only a little bit over a half of those who turned out antibody positives were diagnosed with qPCR, which means that there is probably a fairly large percentage of those truly infected who remain sufficiently asymptomatic not to seek help from the healthcare system. And number 2, that the antibody level, the titer of antibodies against the virus, do not seem to be declining within 4 months of the infection, which is encouraging to see and has implications when people consider immunization programs.
Absolutely. And we hope to follow the patients that had recovered, follow them up, and look for evidence of reinfection in those people. And that will be interesting to see if that occurs and whether that correlates with the antibody response.
And in addition to that, we are going to start a fairly large study of cell-mediated immunity against the virus.
And the long-term consequences of infection, which I think is very important.
We're going to call in everyone who was truly diagnosed, and we are going to phenotype all organ systems. So thank you, Daníel.